Hi, welcome to another episode of Talking with Docs. I'm Dr. Paul Zalzal.
And I'm Dr. Brad Weaning.
And
I'm Dr. Nicole Callan.
thank you very much, Dr. Callan, for being with us again. I know we've had you on here talking about lots of stuff from anal fissures, rectal bleeding, we've been moving up. We moved up to appendicitis, and now we got up to the breast, okay? Yeah. So we're gonna discuss today the situation where you've been diagnosed with breast cancer. What do I do now?
Okay, so the first thing is don't panic. I think that breast cancer treatment has improved so much over the past 30 years that the mortality from this, though present, is still very low. So I think it's important not to panic.
Okay, so first of all, then, how is the diagnosis made? How do I know I have breast cancer?
So it depends on how it was initially diagnosed. Did you feel a lump? Did you go in for screening and it was found on your mammogram? So depending on how it was diagnosed, will just deter. It gives me an idea of what happens next in terms of management. But that's all because of things on screening are going to be smaller than things that you can feel, right?
I see. Okay.
So management is, and the management of breast cancer is so different for everybody. So you can't say, oh, well, Yvette next door had this done, how come I'm not having this done?
Oh, okay.
It follows a similar path, but everybody's journey is different, so.
Dr. Callan, do you have to have a tissue sample to be diagnosed with breast cancer? Can you say, hey, this mammogram looks so abnormal, we know it's cancer, so you have cancer? Or do you have to have a piece of tissue?
Yeah, so the mammogram will oftentimes be a no-brainer for the radiologist as well as ourselves who are looking at the images or even on exam. But without the tissue diagnosis, you really want to be confident you have a diagnosis before you tell someone that, because you don't want to be wrong. But most times there are situations where it's kind of obvious, right? So we always get a biopsy.
Right.
And what will be biopsied will be either the primary lesion in the breast. If usually with imaging, they will look at the lymph nodes as well, and then they'll biopsy any suspicious looking lymph nodes. And that's important because that may change the order of your treatment.
So for patients, a couple of things. One, is that process painful? And B, would they biopsy the lymph nodes at the same time with a needle under ultrasound, or it just depends on the potentially?
Ideally, they would. Okay. However, there are times where you might notice the lymph node on subsequent imaging, and so it might get done at a different time. Is it painful? So, it's not pleasant. I mean, you're going to get freezing to your skin, and then they use, I call it the gun because it makes a very loud click. So that's kind of scary, right? You're sitting there and somebody's using this giant needle that goes click, click. So, but generally a tolerable procedure. And you'll likely get bruising after that. You can get pretty bruised. So.
Okay. After a biopsy. So they take some tissue in that manner. Pathologist looks at it under the microscope and then comes back and says,
this is a cancer. And so generally with your cancer diagnosis, they'll differentiate between the types, so you can have tumors that arise from the ducts or from the lobules. So the breast is made of ducts and lobules. Lobules make milk, ducts transport milk. They're treated the same way. There are some nuances in terms of their differences, how they behave, but generally we manage everything similarly anyways. What you will also have on your pathology report is information about receptors. So what are the things that feed this tumor? Because commonly we will have estrogen as one of the triggers to increase the growth of the tumor. So estrogen, progesterone, and HER2 are those markers that will be identified on your pathology. And those will be important for what are the steps for your next management.
okay, so we have breast cancer. Now, obviously, we want to get rid of it, all right? And do we cut it out? Do we kill it with chemicals? Do we give it radiation? How do we get rid of the breast cancer?
So generally the first part will be surgery.
Okay.
But that can change. So I always tell people, initially I may see you and I may say, okay, we're going to plan surgery first, but then I have to do a workup first. So workup may include more imaging, such as MRI, more mammos, more ultrasounds. And so if along the way we find other things, we may change the order and do chemo first. And so that's not a bad thing. It just means we're changing the order. If you have chemo first, you'll have surgery after. If you have surgery first, you may have chemo after. So there's a lot of
Okay.
differences.
So it's a combination of surgical excision of the tumor and then chemicals, drugs to try and kill any remaining cancer cells. Is there a role for radiation or anything like that?
So radiation will be at the end of all of that. And
Okay.
again, will depend on the pathology and the size of the tumor. The patient, some patients can't have radiation, so there's various scenarios there.
Question. I'm assuming that some cancers potentially could be treated with just surgery. Is that possible?
Correct, yes.
Is there ever a breast cancer that could be treated with just chemo? I'm assuming the answer would be no.
So
my guess.
currently, no.
Okay.
Perhaps one day.
Sure.
Studies are going on right now about that. So
And then the other
in
question.
certain subtypes, yeah.
Awesome. And the other question I have is that a lot of people, I have patients like orthopedic patients that come in and say, oh, they wanted me to have chemo, but I said, no, I'm not doing chemo. So it seems like maybe there can be recommendations made, but they can't guarantee that it's going to be beneficial or that there are other consequences to chemotherapy, as we all know.
So I think the medical oncologists are great because they'll give you so much information about how that treatment is going to reduce your risk
Right.
of this tumor coming back. And for some people, that information is very helpful because they'll say, for me, it's not worth the risk of the treatment for the benefit it will give me.
Right.
So they're pretty good at giving you numbers and to figure that out, I guess.
Yeah.
Okay, so to summarize, you've been told you have breast cancer. First rule is don't panic. And,
Yeah.
and anecdotally to that, I mean, when I see patients in my office for orthopedic conditions, I take a full history. And it's very common where a woman has said, yeah, I was diagnosed with breast cancer. I had breast cancer, 10 years ago, or 8 years ago. You know what I mean? And they're living totally lives without cancer now, but they did have in their past. So just to speak to your point of the don't panic, and now we have very good treatments for it, and the mortality has been reduced significantly.
And you're not alone.
Yeah.
Right. Unfortunately, it's very, very common. So.
Okay, so then you got that diagnosis, you didn't panic, you've gone eventually to a specialist like yourself for treatment, and your treatment's going to consist of a combination or one of surgery plus chemo plus radiation, plus or minus radiation. So those things, but usually surgery is in there for sure. The other adjunctive treatments may be involved as well. And then, so you've had it done, and then after you've had the cancer removed and treated, is there some kind of ongoing follow-up that you do or recommend, or you just say goodbye, you're done, thanks?
No, normally you'll be followed by perhaps your breast surgeon and for sure your oncologist, and I would say a majority of breast surgeons still follow their patients on a yearly basis. Just depends on the relationship. But as long as you're being followed by one of your care providers, usually for 5 years. Usually it's the oncologist because they will perhaps continue to prescribe the endocrine treatment, which is often estrogen blockade. So the blockers of estrogen, who is feeding this tumor, right?
Right. So presumably after 5 years, the risk of it recurring is so low that you don't have to continue yearly checkups with the medical oncology team, or is it?
You still should be having, after surgery, you should be having yearly mammograms.
Yearly mammograms.
Or if you've had a mastectomy, and we didn't talk about the surgery, generally I'll bring patients back every year just to do a skin exam to make sure, because a recurrence would generally be in the form of a small nodule over the skin.
But forever, essentially.
So yearly for life.
I think forever,
yeah.
I mean, I don't think you should ever drop your screening after you've been diagnosed. So.
Okay, and then surgery. What are the surgical options if you do have breast cancer?
So the surgical options will depend on a few things. One, the first and most important thing is the size of the tumor, the presence of additional tumors. So, I mean, if you have a tumor here and you have a tumor here, and a small breast, it's going to be really hard for us to make that look aesthetically acceptable.
Right.
And in that situation, it may be better to have a mastectomy.
So mastectomy means removal of the entire breast.
Removal of the whole breast.
Lumpectomy would be removal of the bottom.
A portion of the breast, yeah.
Okay.
And we for sure know that if you're going to have a lumpectomy, you need radiation to reduce the risk of recurrence.
Okay.
With a mastectomy, you may not. We may have to see what the final size was, what the margins were around the tumor. So mastectomy, you're still not guaranteed no radiation, but there's a chance, and there's a chance you could have some.
Okay.
It's not a no because you have a mastectomy. And more importantly, I was telling everybody, you don't get a survival benefit by saying, take off my breast, I want to live. You don't live longer to do that. So if I and my exact identical twin have the exact same tumor, and I have a lumpectomy with radiation and she has a mastectomy, we'll live the same amount of time.
Okay.
She doesn't get bonus points for having a mastectomy.
Oh, it's good to know.
Unless we've recommended a mastectomy, that's different, because that's where, perhaps there's too much disease or...
I see. Okay, so generally for treatment of a lump, of a lumpectomy and mastectomy, give you the same survival rate.
Correct.
Very interesting.
I guess just the last part of surgery, it's too big to talk about today, but that reconstruction has become a really big part and a successful, important part of restoring some of the other functions and appearance of the breast after.
So I am a very strong advocate for reconstruction,
Sure.
and in the appropriate patient, of course. But yeah, I think that is so important for a woman's quality of life, right? And
Part of the healing.
And part of the healing, yeah.
Okay, I got one more question. I've heard before women who have a strong history of breast cancer in the family, and different genetic tests suggest they're high risk, so they've gone on to have a prophylactic mastectomy without ever having cancer, but they have mastectomy.
Yeah.
Is that a thing?
Absolutely, yeah.
Okay. So what's the deal? What leads someone to say, okay, I'm going to have a mastectomy. I don't have cancer, I'm going to have a mastectomy so I don't get cancer?
So generally in that patient population, the only survival benefit you'll see in a prophylactic mastectomy will be patients who are gene carriers.
Okay.
So if you're assessed by the genetics team, they find a genetic mutation, you will actually have a survival benefit by having a prophylactic mastectomy.
Because you're almost guaranteed to get it. Because your risk is so high.
Yeah.
Okay.
And but most other, so it's very important for us to counsel people that there's if in the absence of a genetic mutation, there's no survival benefit.
Right.
But I do think there's a benefit psychologically for a lot of women. I think sometimes if you've had a mastectomy on one side, that asymmetry is very difficult to deal with. And so I think it needs to really be assessed individually. And if a patient knows the risks of the procedure, then I think it's appropriate to proceed with what is going to make them happy long term as well, right? So
For sure.
Thank you so much, Dr. Callan. To our viewers, we really hope this has helped you if you're in that situation and you haven't had a chance to talk to someone about it. This hopefully is a starting point for you. Thank you.
No, it's really important. Thanks so much. Lots of useful information. We hope it helps. And if you like this video, please like it and subscribe to our channel.
And remember, you are in charge of your own health.
We'll see you next time.